Welcome everyone. We have a great lineup today discussing pediatric foot deformities. I'd like to thank everyone who contributed, all the speakers today on the great lineup, and I hope it's an educational event for everyone involved. We'll have a Q&A session at the end, so please hold for all your questions and we'll get hopefully to have a nice discussion. The first talk for tonight is about pediatric pes planus by Dr. Aaron Brandt, who is an assistant professor in pediatric orthopedic surgery here at NYU Langone Orthopedics. So without further ado, get started.
All right. Thanks, Kareem. Good evening. I'm Aaron Brandt. I'm one of the newbies here, but a part of the pediatric department. And we'll be talking about flat foot. 15 minutes is a short window to talk about these topics, but hopefully we can kind of go through and discuss some of the findings that you'll see with pediatric flat foot, but also when to refer is kind of my goal overall, because a lot of times it's not something that's dangerous or problematic. So I have no disclosures. I just skipped past those slides. So we'll talk about kind of what is normal a little bit. I'll spend a little more time on the anatomy. I have the probably simplest topic to lead in, so it works out that way. We'll talk about kind of why feet actually do become flat and what's problematic. How do we evaluate those? And then what can be done or what should be done. We'll briefly kind of hit on that as well. So the foot, fairly simple in what we ask it to do as humans. It's obviously a platform, holds our body weight. That's an important factor. Body weight makes a difference as far as symptoms and problems and flat foot in general. So something to keep in mind. It functions as a tripod, so we want the tripod as sturdy and well-balanced as possible, which is where these deformities come into play. It is not that simple, though. So feet have many functions. They stabilize us. They propel us forward. They absorb shock. They're also important for style. We know how important shoes are. And that is actually a factor that often comes into play when we see these as consults and people want to see it. So the cosmetic side is a huge factor here. They are very well built and built to adapt. I think I geek out a little bit just because, one, I have an issue with my own foot, so it's something that is near and dear, but it's also pretty impressive what they do. And we ask a lot of a pretty simple design. So the bony structure is very well made, well constructed. It has a keystone type design. So the bones do offer some architectural support, more so in the axial plane. So if you look at the cut through the midfoot, all of these kind of key in well. And if those are not supporting each other, they aren't holding a good arch. The arch in general is what we define as kind of a good foot structure. And we'll get into kind of the flat foot and the cavus. Dr. Latrenta will hit on the cavus version as well. We also have support from the ligaments, plantar fascia. Again, just highlighting that keystone. The muscular attachments and function are also well designed. I mean, this is just simple physics that we see every day, but the pulley design of the calcaneus and Achilles and plantar fascia attachments also work well together. So if those structures are not functioning how they should or not attached in the right location, it's going to affect how well we can really use the foot, but also what it can do for us. So what is flat foot? And really I'm going to talk about a few of the issues with flat foot, but what we're talking about is just loss of this medial arch. We make it very simple. We describe it just in one way, but it's a relatively complex issue, but often not an issue. So flexible flat foot is often physiologic. It's hyperflexibility. It's ligamentous laxity. And in pediatrics, that's especially true. A lot of the flat foot really is not problematic. It's just related to flexibility and development. We say that there's an unknown incidence, really just because a lot of flat foot is not symptomatic. It's not something that is seen. The numbers can be anywhere from 25 to a third of adults. I use the kind of rule of thirds for patients to describe it because it is truly on a spectrum. The vast majority of flat foot really is normal development, along with some of the other findings we see in kids, genuvarum and valgum, internal torsion, femoral anteversion. All of these are abnormal developmental findings, but they're also part of that normal development. They improve with time. I have there the rule of thirds, but flat foot is part of that in my opinion. It's part of that spectrum of development. And what we want to find is the versions of flat foot that are going to be problematic if we can try to catch them. So we want the bridge to stay a bridge. Excuse me. So describing flat foot, really the classification that is important, or kind of how I approach it, is really just, is this hypermobility or is this rigidity? So hypermobility is, again, the idiopathic versions, the familial, those hyperlaxity. I threw in accessory navicular just because of these. There's association with flat foot and that hyperflexibility. It is not a cause, but it's just something I wanted to touch on as part of the spectrum. I'll jump down to the rigid flat foot. We're going to touch on coalition, congenital vertical talus, and oblique talus. And then part of the hypermobile version, we often talk about just pes planus, but one key distinction that I really want to make sure everyone walks away with is this gastroc soleus contracture, or tight heel cords. This is to me a huge factor and a huge problem for kids, and something that we actually can impact and improve to help the foot develop correctly. So a tight heel cord is going to impact the development of the foot as far as how the hind foot can move, and further influence kind of how that foot develops. And we'll kind of move into that a little bit more. And so what do we need to ask ourselves? It's what is really going on? What's causing this flat foot? Is it something structural? Is it actually something, deformity, if you will? So you can have deformity through the bone. You can have loss of support from those structures that we talked about, the attachment sites. You can have a functional issue. So in adult flat foot, a common or a culprit in that, and an important factor, is that the posterior tibial tendon. In kids, it may be symptomatic, but that is very rarely the primary cause or the primary issue with these. So I keep it in there because it is part of that spectrum and the process of aging, but typically that is not the contributing factor. Contractures, like we said, the tight heel cords, and we'll get into that here in a second. And then Dr. Karamatopoulos will kind of touch on some of the neuromuscular conditions that lead to this as well. So general weakness and just lack of ability to support. I had the causes. I had a mentor that kind of hit me on the head with making sure that I never forgot all the causes of different conditions that we can run into. And really any of them can play a role in flat foot or pathology of the foot. The ones that matter most kind of for that pediatric population are the idiopathic hyperflexibility, congenital, so some of the deformity that we're going to talk about, and then developmental or compensatory. I don't even have a foot on here because this is a very commonly seen problem. You have genuvalgum or knock knee, which automatically causes that internal position of the foot or that flattening of the arch. And so the problem is not so simple. It's not just that collapse. It's not just collapse of the arch. There's a lot of different things at play, and I think that that's something important to recognize. They all contribute to each other, and this is where we're talking about that hind foot and the gastroc contracture being a big problem for kids, or one of the main things that I look for when I do evaluate flat foot. You also have the midfoot abduction. We'll look at that a little closer. And then forefoot supination, and we'll go into that. Pronation is kind of what we all talk about. I'm sure that's something that is talked about with patients because I hear it every time. I hyperpronate, or my foot is hyperpronated, is what they describe. But what is really going on is there's supination through the forefoot as part of this kind of third layer, if you will. So we'll get in that here in a second. So the hind foot, the ankle does turn in, so it does pronate relative to its the position it should be. We call this hind foot valgus. It's really a positional issue. It's an angulation through the hind foot itself. And what's important to look for is heel rise. Does that heel turn in? So does it correct? When you have hind foot valgus and a tight heel cord, that foot has trouble doing that. So you may see this as toe walkers, similar problem. They will either toe walk or they'll be able to drop their foot down, but they'll have a very flat foot because of it, because they cannot get their foot flat with the heel in the right position. Midfoot, we have an uncoverage of the talus. This is an important finding on X-ray. I talk to patients that I want to see the cap on the center of the head. I don't want to see it off to the side. And then this pronation supination. We know that the forearm does this. I try to describe this to patients and take them through this, but pronation similarly is rotation through the forefoot through a fixed point. Supination the other way. And what I want to highlight is now we have the heel nice and centered. So with flat foot, when we correct the heel, the forefoot goes into supination. And that's what is important to recognize. That's not just that hind foot that we have to correct. It's also the forefoot when we are managing these. Flat foot pus. These are the ones that I really want to make sure people look out for. These are the ones that usually are going to cause problems and actually cause pain. Tarsal coalition is a failure to segment of two or more of the bones. Autosomal dominant, so it may run in the family and often in males. You'll see it in the calcaneonavicular and talocalcaneal joints. But what happens is it limits the motion of the foot and can cause adjacent kind of arthritis, but really impingement and things like that. So if you're foot pain, flat foot, we want to check on the mobility and make sure that they don't have a coalition. So x-rays, I cannot advocate for it enough. If they have a flat foot and they're not moving well, an x-ray is important. It's not just throwing them in an orthotic without taking a look closer. That accessory navicular, this is really my only slide on that because it is a normal finding, supernumerary bone. It can have varying degrees of size, but really what happens is they can become symptomatic from pressure on the area and then inflammation of the posterior tib tendon. So it's really non-op treatment as much as possible unless they really can't recover or can't return to their activities. The procedure is pretty simple for us. It's just open, remove the bone, and reattach that tendon. Congenital vertical talus, another bad actor. These are what you'll see a little bit earlier in life. But this is a rigid deformity. This is a rocker bottom deformity. You have a dislocated joint through the talonavicular joint, but it's fixed. And so this is one of those, a flat foot that just is not going to come back and is not flexible. So check the feet. The sooner we find it, the better. After age 3, really the options are not very good. We really want to get that joint reduced. It's associated with many conditions, but just something you don't want to miss. And then oblique talus is kind of the in between of those. So try to keep moving here. The presentation for these and is variable. Usually it's just the feet look flat. Sometimes you will have mid-arch pain, lateral ankle pain, but a lot of times this is not actually part of the issue. For the most part, it's usually a cosmetic thing that leads to the evaluation. What you need to know is kind of how long have the feet been flat? What are the visual findings? Is there any skin breakdown, callus, things like that? How does it affect them? Is it really kind of limiting them? And then what is the main concern? I always ask that is what's the concern about the feet? And then often it's what they look like. 2 too many toe sign, that hindfoot valgus we talked about. Again, make sure you watch them walk, and then I make everybody heel and toe walk as well. I do that for any hip, knee, ankle, everything. And then this goes back to that testing of the hind foot or the heel cords. We want to see a silver skull test. This is testing with the knee straight and then the knee bent. The important thing is getting that hind foot neutral. If you try to test them when the hind foot's not neutral, they are going to flex through the wrong joint. So get that heel underneath and really test. Imaging, feel free to get imaging, depending on your practice. Obviously, you don't. If you don't feel comfortable, send them our way, and we'll kind of get our studies. But weight-bearing images are important. We can really underestimate flat foot when they're not loading. So the AP, again, we're looking at the coverage. We're also looking at the joint height. So in pediatrics in particular, compared to adults, we often get shortening of that lateral column, which is a big factor and a big part of correction. So we'll kind of touch on that briefly, but the lateral column length is shorter. Is that developmental as a limitation in development from the problem itself, or is that part of the spectrum of disease? That I don't know. The lateral, we're looking at the arch. Again, this is Meary's line, so straight down the talus, straight down the toe. When the angles do not follow each other, that's that collapse. Also look for just little areas of impingement, bone spurs. The oblique x-ray is great just for simple looking at other bony structure, bony anatomy. This happens to be my foot, shared with permissions, but this is an x-ray at 30 when that foot is far too along the disease. So something missed, and this is kind of what you'll see is just a lot of arthritis in the joints around. MRI and CT are really left for evaluation, pre-op or more complex evaluations. We also want to make sure that we're not missing anything, stress injuries, osteomyelitis. Focal pain is something you need to pay attention to. I think if they're describing pain in one spot, you have to kind of pay attention to that. And then briefly, we'll go through the treatment. So orthotics are often used. I really try to leave it alone. I think development is development. I think the sooner we throw orthotics or braces or anything on, we're affecting that normal development. So I really do try to leave orthotics to kind of last line or treatment of symptoms. Shoe wear modifications are very simple. Just making sure they're wearing good shoes. And then symptomatic stretching, PT, casting, something we can always try. Again, the orthotics. And then braces are, again, rarely used with flat foot. I use them more as a last option. We talked about the stretching and what's important. I think it's critical that therapists and everybody pays attention to the foot position. We can send for stretching, but if they're not stretching with the hind foot underneath, they're not lengthening anything. They're stretching through that midfoot joint and actually probably making it worse. So very important. I try to talk to them about sticking something under their heel at the very least, or using their orthotics when they're trying to stretch. Closed chain stretching are kind of the things that I try to reinforce. And then operative correction is really addressing those issues. So I talked about the lengthening. This is called the lateral column lengthening or an Evans lengthening, where we make a cut in the bone here and we lengthen through that with a allograft. And then we use a opening wedge because of the supination deformity that's still present. So we actually have to bring that toe down after we correct the hind foot. Often we don't have to do any slides. I think Dr. Latrenta will talk about that a little bit in her talk. But if we need to for severe deformities, we will also manipulate the calcaneus. Here's a couple just with that correction. Just the lateral column lengthening is really powerful. It really does push that joint up and shift that bone over the top. Coalitions, resection is kind of the standard if they're recalcitrant. The calcaneonavicular are the most common. Those ones are a little more straightforward, but we can't miss deformity. If there's deformity associated with the coalition, you want to correct it as well, because just resection is not going to be enough. So I call these the resection plus procedures when necessary. So make sure you're evaluating the whole foot. Don't get hyper focused on that one spot. And this is an example of what that coalition resection. This was actually just a simple that did not need any correction and nicely removed. This is a young lady with a subtalar that required a resection, but especially the subtalar joint coalitions, if you remove them and don't correct their deformity, they are going to be in pain. So I've had to do a couple secondary corrections because of that. Again, very nice, powerful improvement. And then congenital vertical talus, often if we get them early enough, we can treat with casting, operative intervention if necessary. These are rigid. We don't want to miss them. So the later in life, if we get them, the only answer really becomes arthrodesis or fusions. So take home points, and sorry to kind of race through that, but flat foot is very often not painful, and a lot of times the pain is not related to it. So we need to kind of tease through that. Examination, things that everyone can do: toe walking, have them heel rise, look for that flexibility in the foot. Also looking at range of motion, but making sure that we correct the hind foot to be able to do that. So not missing those aspects. Treatment really depends on the reason. Even if they come with a coalition, things like that, there's still a process that we go through as far as conservative options first. But the majority really will not require any treatment. And then we don't want to miss deformity. We want to at least be aware of it, be able to follow it. So if you ever have any questions, please just forward our way. Happy to see them. So if that arch comes up with heel rise, if you see the hind foot go in, if you just have the foot dangle off the bed and the arch restores, probably going to be okay. Thank you.
Thank you very much. That was great. I'm sure there'll be a few questions following up on that, but let's move forward and go to the CAVIS talks with Dr. Jody Latrenta.
All right. Thank you so much for starting us off. And thanks everyone for joining us tonight. As Dr. Mazruha said, I'll be doing the CAVIS foot talk, covering the etiology and the exam findings. We'll go over non-operative and operative treatment. And then I'm going to review some clinical scenarios from some of my patients. There's no disclosures that I have relevant. So CAVIS foot is a deformity unlike flat foot. It's going to be characterized by a high arch and a clawing of the toes. And it's caused by an imbalance between the intrinsic and the extrinsic muscles of the foot. The vast majority of these are going to have a neurologic origin, and the most common one is going to be hereditary sensory motor neuropathy, and that would be something like Charcot-Marie-Tooth. CMT has a genetic origin. There's a duplication in the gene for peripheral myelin protein on chromosome 17. We also have to look out for spinal cord abnormalities. So if you see a new onset CAVIS foot, it's a good idea to get an MRI. And certainly a CAVIS foot could also have a post-traumatic or an idiopathic etiology, although that is a bit more rare. And in most scenarios that we see, the earliest signs are going to be present in adolescence or in the young adult, and they can actually lead to progressive deformity. The typical CAVIS foot is driven by a combination of a plantar flexed first ray, and you see hindfoot varus as well. So you get the high arch that's shown in the top image, and then the varus heel, as you can see on the left compared to the right in the bottom. So we get kind of a variation of the tripod effect that we talked about in order to balance the foot. So when someone has a CAVIS foot and they're trying to push off in the normal gait cycle, the forefoot ends up supinating to align the metatarsals and put them on the ground to create that necessary force for that action. And then this in turn is going to push the hindfoot further into varus. And you can see that in this illustration here. Again, it's of the left foot. So you can see in image B that plantar flexed first ray compared to the lateral aspect of the foot. And then to try to get that foot to lay flat, which is what you see in image D, the hind foot, the heel, is going to have to compensate and assume that sort of varus position. Muscle imbalance is going to be a hallmark feature of cavus deformity, and typically the peroneus longus, which is the bigger muscle than the brevis and less susceptible to the pathology, is going to be strong, and it creates the deforming force on the first ray, which I mentioned is plantar flexed. The tibant is going to be the weak muscle compared to the tib post, and many patients are going to be seen to have a steppage gait or actually a frank foot drop. I'm going to do a little shout out here to one of our other faculty members, Dr. Andrew Price, who actually did an imaging study looking at the different patterns of muscle atrophy that you can see in different types of cavus foot. And importantly, notice that in all cases, they're significantly weak intrinsic muscles, and that the intrinsic muscles are affected quite early and quite severely. This is a clinical test. It's called the Coleman block test, and it's done to help demonstrate the pathology and help determine the severity of the condition. So in this test, what you do is you place the lateral aspect of the forefoot on the block. You can see that in image B. And this allows that first ray, which wants to plantar flex, to allow that plantar flex position. And then the hind foot is, which normally would have to be in varus to be plantigrade, now can compensate. And it doesn't have to go into varus, and it can now go into sort of neutral or even normal valgus alignment. But since the cavus foot is a progressive condition, over time, the foot does not correct on the Coleman block as it becomes more stiff and fixed in the far right image. The hallmark of treatment is that the flexible and the fixed cavus foot deformities are treated differently. So on the spectrum, options, of course, are going to be bracing and a variety of surgical options that I'll go over. So bracing is going to be an AFO. We talked about the weak dorsiflexion, so you need to support that. And there's going to be a post under the lateral forefoot, which is basically the same idea as the Coleman block, trying to allow for that passive correction of the heel by allowing that first ray to sort of drop down when the lateral foot is posted up. We're going to do soft tissue procedures for these flexible deformities, and then we're going to incorporate osteotomies or even an arthrodesis, which is a fusion if we get a stiffer foot with a fixed deformity. And really, in all cases, physical therapy is going to be paramount to treating the gait dysfunction. In the early stages of cavus foot, the soft tissue lengthenings are for sure going to be the Achilles tendon and the plantar fascia. They get tight early. And you're going to need to address them really in most surgeries, whether it's a flexible or a fixed deformity. So what we do is a way to lengthen the Achilles tendon, and then we can also transect the plantar fascia that you can see here so that the foot can be passively brought into a neutral braceable foot position. Because I mentioned that muscle imbalance is a core principle in the underlying pathology, the tendon transfers are going to make sense. So we talked about how the longus overpowers the brevis, and you can see where it is inserting here on the plantar aspect of the first ray. So if you take the longus and you transfer it to the brevis, it's going to serve a twofold purpose, removing it as a deforming force on that first ray, and then also augmenting the strength of the brevis laterally. And what you do is you make an incision on the lateral aspect of the foot where the tendons pass behind the fibula, and you just cut the longus, and then you suture it side to the brevis. Clawing of the toes is a significant thing because not only does this lead to gait dysfunction, but it's also one of the most common things that the patients complain about. I don't like my high arch, but I really don't like how my toes look clawed. And what we can do there is actually relax. We can actually cut the flexor tendons on the lesser toes and remove them as deforming forces. They can sometimes be transferred to more proximally to the metatarsals as well. And then on the great toe, you can have significant clawing there. And what kind of can contribute to that is not only the FHL, but actually the extensor side, the EHL. It becomes quite taut. and you can take that off where its insertion is and then move that more proximally on the metatarsal neck as drawn here. And this, again, kind of serves this twofold procedure. It removes this, as a deforming force, and then it's also going to counteract the plantar flexion force that's on the first ray. And that's going to be called the Jones transfer. We know that the long-term results of surgery on flexible cavus foot are actually really quite good. And that means that we have relatively low rates of, secondary surgeries in patients. And that if we follow them radiographically, we're not seeing development of osteoarthrosis. We should still know that these feet are not totally normal, and that if we look at outcome measures compared to age-matched norms, these patients do score lower. Okay, so patients with a more severe deformity, a fixed deformity especially, are going to need a bony procedure. And that's going to be osteotomies within the forefoot, midfoot, or hindfoot, and then considering arthrodesis in more advanced cases. So starting with the first one, the first two common osteotomies to correct that high arch are going to be a dorsiflexion or closing wedge osteotomy on the first metatarsal, or a plantar opening wedge osteotomy in the cuneiforms. So to understand how these work, I'm going to have you just sort of consider just this part of the foot in isolation where the wedges are working. So a closing wedge of the bone is going to be removed from the dorsal side of the first metatarsal to take it out of plantar flexion, and then another wedge of bone, which would be an allograft, is wedged in the cuneiforms after you cut it with an osteotome and open it up, so that you can correct that apex of the arch deformity in the foot. And so just to kind of see, here it is again, you can see the purple triangle where the wedge of bone is placed to open the cuneiforms and correct that high arch by the depressed first ray. So there it is, opening the cuneiforms, but the first metatarsal is still kind of dropped down. Foot isn't quite plantigrade yet. And then if you take out this wedge of bone from the first metatarsal, you can get a much more plantigrade foot. And then, of course, I mentioned that the varus heel is a problem. So in many cases, you're going to need to correct the calcaneus to take it out of varus. So in the upper image, you can see the calcaneus would be cut, and then it's going to be moved laterally to sort of offset that varus in medialized position. You can also try to do a little bit of a, kind of a closing wedge here as well. And then if you have an end stage patient with a very sort of a weak foot, they're not going to have a lot of typically motor control owing to the neuropathy as part of the condition, and they're going to have these very fixed sort of stiff feet. You can correct the deformity by doing an arthrodesis through the joints themselves. You're going to go in, denude the cartilage, resect as much bone as you need for the correction, kind of pictured here, for example, in the subtalar joint. And then what you do is take out the rest of that cancellous bone and then fuse it. And this is really going to give you sort of a stable, plantigrade foot to walk on. So I'm going to show like a few sort of pertinent examples here of some patients that I just want everyone to kind of take with them. So this first case is a 17-year-old girl. You can see she had bilateral CMT, but really, really significant deformity in this right foot. That staple is because she already had an attempt at, a closing wedge on the first metatarsal, but she's really got an arch that we needed to correct with a number of osteotomies, as well as a fusion to give her a plantigrade foot. There she is with the plantigrade foot. So I was pretty happy with this result radiographically and clinically looking at it. The story for her is that she still had a fair amount of neuropathy in her foot. So despite the orthopedic side of it giving her a stable base to walk on, she was still having too many neuropathic symptoms. And she actually came to me because she had been using the iWalk, which maybe some of you have seen. It's like essentially you bend the knee and it's strapped to the knee, and then it's like a prosthetic that's off the end of the knee so that you can be non-weight bearing on the ankle. And she was pretty good at that. And, she ultimately went on to actually have a below knee amputation because the neuropathic symptoms were just like so severe for her. So a really kind of humbling thing to think about, orthopedically that it's not just the structure, but it's the nerve as well, the neuropathic part of it as well. Can we play this video here? Trying to, maybe not. And then there she is. That's actually her walking after she had her amputation. So you can see that fortunately she did really quite well with that. The next one is another 17-year-old girl. Note this. Know that these are all adolescents, right? They're all coming in, right around this age with this onset of this neuropathic condition. So I was actually seeing her because she had these patella dislocations, and she was having a really hard time recovering from them. And she was always coming back in using her crutches, and I couldn't figure out exactly what was going on. And I sent her for an MRI. And I sent her for the MRI to look at the knee joint, but what you could actually see is that she had very abnormal nerves on this MRI, very hypertrophic nerves. The radiologist picked up on it and says, this looks like a peripheral neuropathy, like Charcot-Marie tooth. And I thought, really, are you sure? I've been following her. I don't think this came up at all. And then lo and behold, this is the patient whose foot I've been showing you in all these slides. So we took off her socks and shoes and talked to her a little bit more. And she said, yeah, it's not really my knee I'm using the crutches for. It's the fact that I can't move my feet so well. So hopefully we've got her on the right track now. The last one I'll show you is a 16-year-old girl who came in. Pediatrician referred them for scoliosis evaluation. The mom says, I don't know that it's scoliosis, but she just walks funny. Something doesn't look right. And I said, okay, how about we just go get an EOS so I can check your entire alignment. And then the resident came up to me and said, oh, they came up to me later and they said, would you give us a PT prescription? Her Achilles are really tight and we'd like to work on that. And I thought, okay, that's a little weird, but sure. And lo and behold, here's her EOS. And if you really look closely, this is her pelvis. This is bilateral hip dysplasia with subluxation. This is caused by a peripheral neuropathy. So when you see this, again, think Charcot-Marie tooth, and here are her cavus feet. Okay, so in summary, remember, you may be the one to diagnose cavus feet. You will see some of these patients, and I hope this talk has been very helpful, and I'm looking forward to hearing the rest.
Great, thank you so much. That was amazing, and very very insightful. It's like we can see different deformities that might trigger us to think like, oh yes, let's take another look at those feet. All right, so I guess I'm the next speaker. I'll be talking about toe deformities and malformations. I think that sometimes toe deformities are underappreciated, maybe overlooked. So we'll highlight them over here. Oh, sorry, went too fast. I'm going to disclose. So obviously, talking about toe deformities in a short period of time is challenging, and so it is by no means comprehensive. But I will try to touch on these deformities and malformations. So the hallux varus deformity, hallux valgus in adolescents and juvenile patients, and dorsal bunion overriding fifth toe, and the malformations of macrodactyly, polydactyly, and syndactyly. So congenital hallux varus, it's basically a varus alignment of the hallux, as the name suggests. It's associated with a longitudinal epiphyseal bracket, and this is basically a medial extension of the epiphysis in a shortened metatarsal that needs to be taken down in surgery, and it can be associated with preaxial polydactyly, as in the patient that's shown here. These can be identified in utero on the scan ultrasound that's done usually at around 20 weeks. There's usually no other associated deformities, and it typically persists, and it can lead to extremely difficult shoe wear, as it would clearly be noticed here. And so there's no role in non-operative management. So here's a case of a patient who came in at around 17 months, difficulty with shoe wear, had been starting to walk around. And you can see there's a polysyndactyly as well, that's preaxial there, in addition to the alignment of the misalignment of the foot. And so this is typically corrected through a procedure called the farmer procedure, where a flap is taken from the web space, the first web space, and transferred medially, and the toe is realigned along with the metatarsal, and then pinned in place temporarily. This once scarred, it's scarred in, typically heals very well. There can be some syndactylization in the first web space that can help maintain the correction as well. In this case, also the polydactyly was the extra toe was removed. And so, by realigning the foot, then shoe wear can be more accommodative. So, in the other end of the spectrum is the adolescent hallux valgus patient, and the picture over here is of a teenage girl, not an elderly female. So it can happen in young patients and can be quite severe. Typically, is runs in families in these severe cases where the hallux is laterally subluxed. It's more common in females. Non-operative management is usually the mainstay initially, with wide toe box shoes, no heels, and using nighttime stretching that are available over the counter. However, with operative management, just as with adults, it can be controversial. There are all sorts of techniques, scarf osteotomy, distal and proximal osteotomies, and the imbrication of the first MTP joint capsule. In my opinion, having a minimally invasive distal osteotomy with imbrication and proximal phalanx osteotomy usually gets the job done with a less invasive approach. But that's not always necessarily the case, as over here, the intermetatarsal angle was quite severe. This patient had tried all sorts of things for over a year, and they had significant pain over the dorsum of the second toe with shoe wear, as you can see, because that first toe was so deformed. In these patients, it's important to also look for hindfoot valgus and gastroc tightness, which she didn't have. So with this patient, I did a proximal osteotomy and medial imbrication with excision of the bunion. Over here, a proximal phalanx osteotomy was not performed to basically line her up with the other side, though it could be helpful in these cases. And so this was the result. So the foot is better aligned, and that second toe is able to have a little bit more space. But this is the more frequently done procedure in my hands, and it usually gets the job done through two small incisions with pretty good results. The deformity, when more severe than this, can result in a strange appearance of the X-ray when fixed with these screws that come across. Dorsal bunion is typically a secondary deformity. It happens in patients with clubfoot who were treated surgically when they were much younger. It's due to overpowering of the toe flexor and the tib ant, and so the foot tends to have this sort of flex deformity at the first MTP, which can result in irritation of the dorsum of the foot. In this patient, she had some irritation there with shoe wear and pain in the toe. And so we attempted shoe wear modification. However, that was unsuccessful. And in her case, she had to undergo a correction. And so it's basically the reverse Jones, as Dr. Trenta had mentioned. The Jones procedure is the transfer of the EHL to the first metatarsal neck. Over here, it's the FHL that goes to the first metatarsal neck through a drill hole and sutured onto itself. And the final result is her having a flatter foot that she can walk on. Patients with congenital overriding fifth toe, it's not as common. There's also there's a contracture here of the EDL, and that fifth toe is dorsiflexed, adducted, and externally rotated. It can result in significant discomfort, although stretching and taping can be very helpful. There are a couple of procedures available that can try to correct this condition. The Butler procedure is basically two racket incisions. One that's the V that becomes a Y, and that's the dorsal one, and the plantar one is a Y that becomes a V, and that's when you bring down the toe. In addition, you perform an EHL tenotomy and dorsomedial arthrotomy of the joint, and thereby bringing the toe into alignment with the rest of them. The other procedure that's been described is a tenotomy of the HL more proximally. That's then sutured to the fourth toe extensor, and then the distal aspect of the tendon is flipped around the toe and attached to the abductor, thereby abducting the toe and bringing it down. So both have been described. Butler is certainly the more commonly performed procedure, and here's a post-op example of a patient courtesy of Dr. Latrenta. So macrodactyly is quite interesting. It's a difficult condition to manage. It's overgrowth of all of the tissues, the vessels, the subcutaneous fat, the skin, bone, everything is overgrown, and it's progressive during growth. So attempts at debulking can be performed. However, the remaining tissue will continue to overgrow, and it's unrealistic to expect non-operative management to work in the long term in these patients. So there are options such as epiphysiodesis, but that only stops longitudinal growth, but not circumferential growth. And so ray resection tends to be the most reliable. So there's a patient who had significant discomfort from that second toe macrodactyly, which is fairly common. And the difficulty here is to try to resect as much of the abnormal tissue as possible, because there's no demarcation of what's normal and what's abnormal. So that can be a little bit of a challenge here. So I tried to go as proximal as possible, resecting that metatarsal as high up as possible, and then bringing the foot in, and that helps with accommodate. An extreme case of that is in a patient with Clove syndrome. So that's a patient with a congenital lipomatosis and vascular malformation and nevi and scoliosis. And so this is a patient with that condition. And as you can see, it would be very challenging to wear any type of shoe wear that wasn't custom made for this patient. And so the goal here was to try to narrow the foot sufficiently in order to fit into some sort of shoe wear. And so this is where which toe do we take down, and try to take down the second toe here as well, and make the foot as narrow as possible in order to fit into a shoe. So polydactyly, it's one that we see more frequently in the office. Patients usually come fairly young. The parents concerned about that extra toe. They can have a positive family history. 2 or more extra toes in syndactyly consider that possibly a syndromic cause. There can be preaxial, central, or postaxial. Postaxial, as with this patient in the picture, is most common. And so they can be complex or simple. And usually shoe wear difficulty is the problem here over time due to the wider foot. And you sort of narrow it down by removing that extra toe. And so this is the well-known Van Wasten classification, and it's usually used to describe the source of the deformity. And so here's an example. And sometimes it's a little bit challenging, like which toe needs to go, right? Is it the toe that's sort of plantar flexed over here, or is it the sixth toe, the more lateral one? It seems like that over here, the sixth toe kind of lines up with the rest of them. But, when you look at the X-ray, it's just a widened fifth metatarsal, and, both are kind of equally developed. And so it's by elevating that sixth toe, you see that fifth toe kind of like sits back up where it's supposed to. And tends to be the safer procedure to perform a more lateral kind of based incision due to the blood supply to the toes, and you don't want to compromise that. And so in this case, that's what was done. The more lateral one was removed with this result. And sometimes it's a little bit more obvious from the X-ray. Over here, both toes are, similarly developed, and it wasn't very clear, should we remove the lateral one or should we remove the more medial of the extra toes. If you look at it from above, that fifth toe looks a little bit better aligned than the sixth toe. However, when you look at the X-ray, that fifth metatarsal is significantly underdeveloped, and that's clearly the toe that needs to go. And so, so in that case, instead of the more lateral one, the more central one was taken out, and here you can see excised along with the underdeveloped metatarsal that came with it. And that was the resulting appearance of the foot. Syndactyly is a little bit less of an issue. In particular, it doesn't need to be addressed in most patients unless it's a polysyndactyly situation. It's generally a failure of segmentation that can occur anywhere from the web space all the way up to the toenail. And in patients who have fusion distally, acrosyndactyly obviously needs to be considered, such as the amniotic band syndrome. Surgery is rarely ever indicated. I personally have not ever performed this. Parents come in with some sort of concern. Usually, there is a family history. Maybe the patient's father has similar looking appearing toes. I tell the parents that maybe they swim faster, but there's no need to take down that syndactyly and potentially risk or have any risks related to the surgery. Particularly, there can be syndactylization down the line from scarring. Thank you. So move on to our next talk. And that will be Dr. Mara Karamatopoulos, who will be talking about foot deformities in patients with neuromuscular conditions.
Thank you so much, Dr. Masruha. So we're going to switch gears a little bit here, and I think you'll find that there's some common themes with things we've already discussed. Obviously, we're going to discuss deformities that have already been talked about, but in a very different context, and that's the context of children that have cerebral palsy. As many of you know, some of the concepts in CP, because it's better studied than some of these more rare conditions, can be extrapolated to other things, but we're really going to be focused just on CP in this talk. So we'll try to get through in the allotted time. Okay. Sorry, guys, I have nothing to disclose. Okay. So CP, as everyone on the call knows, most common motor disability in childhood, and it's the result of an injury to the brain that occurs less than 2 years old. So your 5-year-old child with a near drowning can be considered to have a CP-like condition, but not strictly CP. So we do try to keep with that under 2-year-old time frame when we talk about CP. And the incidence in the US has essentially stayed the same for several years. It's estimated to be between 1.5 to 2.5 per 1,000 live births in the US. And foot deformities are remarkably common in up to 80% of children with CP. Typically, we use something called the GMFCS classification, which I'm sure is well known to everyone on the call. You've probably all seen various graphics like this before, but it's essentially a way of communicating from level 1 to level 5 in terms of ambulation and function. So our level 1 through 3s being our ambulatory children, and our 4s and 5s being children that are primarily non-ambulatory. And that's a really good context to think about treatment protocols for these patients, because the goals are going to be very different depending on whether they ambulate or they do not. So the natural history of foot deformity in CP, much like foot deformity in general, and I think Dr. Brandt alluded to this, is that you really don't know when the child is quite little what the foot deformity may be. In CP, the foot deformity ultimately may not be apparent until age 7 to 8. So the overall tone and the anatomic classification, meaning quadriplegic, is it unilateral or hemiplegic, is it bilateral or diplegic, that's going to help determine the most common deformities and also the treatment. In ambulatory children, this deformity is going to limit gait efficiency. In non-ambulatory children, the deformity is going to prevent comfortable shoe wear as well as orthotic wear. And so there are many deformities and they get quite complex, but I wanted to touch on the 3 most common that we see, and that's equinus, cavovarus, and planovalgus. So I'm hoping to give you a little bit of an algorithm and a framework within which to see these 3 deformities, because it gets very complex very quickly, as we'll see. So let's start with equinus. This is the most common foot deformity that we see in CP, and initially treated with physical therapy, plantar flexion controlling orthotics, which we'll hear about from Jessica Hubert in our next talk, as well as the consideration of something called serial casting, which is a way to cast out or give a little more motion for those kids, especially the very little ones who do have a bit of equinus contracture and for various reasons may not be operative candidates. Just as an aside, and I'm sure Jessica will allude to this, you really want to make sure that they have knee immobilizers as well. And that also helps to get a stretch through both the gastroc and the soleus while they're undergoing casting. And then finally, surgical management. So this is really only an option in the older children or in young children where orthotic wear has become challenging, where they have increased contracture to the point that non-operative measures are ineffective, or a midfoot break. And as Dr. Brandt alluded to in his talk, you really want to be careful during the physical examination to really get the calcaneus in neutral, or else you are going to think you have much more dorsiflexion than you actually do. And this is something that we teach our residents. So in thinking about what surgical releases to do, so you say, okay, this kid has failed everything. I believe they need a surgical procedure. Your physical exam is really going to determine your zone of surgical release. So we talked about the silver skilled test in Dr. Brandt's lecture, and this is really paramount to see whether or not an Achilles lengthening would be advised versus a gastrocnemius release. And so this is very important because if only the gastrocnemius is tight and you do an Achilles lengthening, you could see how that would be very problematic. It can lead to over lengthening. And so because over lengthening is so bad, it is not really fixable surgically, and can lead to a very profound crouch gait pattern. Many surgeons who treat children with cerebral palsy will err on the side of treating the gastrocnemius and not doing an Achilles lengthening if possible. The best paper looking at this is one by Ben Shore that now I can't believe it is almost 15 years old, looking at a systematic review of surgical correction of equinus in children with cerebral palsy. And they showed that children under 8 who have an Achilles lengthening will have a very high rate of recurrence, and that over lengthening is quite common. And so you should always err on the side of making them a bit tighter as opposed to a little bit looser. In fact, it's so difficult for people to come to consensus that they actually performed a Delphi consensus study looking at indications for gastroc-soleus lengthening. So this is a procedure that in the past had been done all the time, very routinely. We still do it often, but now our indications are much more conservative. There's some very smart people on this paper. I would encourage you to read it if you treat these patients. I mean, it really gives very good tips on how not great the literature is, and so expert consensus on what should be done is really critical. So when we talk about procedure choice, we talk about zone 1, which is addressing the gastrocnemius only. This is preferred in younger patients and in diplegic patients to avoid overcorrection. And zone 3, or tendo-Achilles lengthening, is preferred in hemiplegics who can have a more severe contracture and obviously more asymmetry, and those with very severe contracture. So the take-home points are to maximize non-operative management, increased recurrence of index surgery less than 8, increased incidence of over-lengthening in diplegics, and to err on the slightly tighter side. Let's move on to varus. We heard an excellent talk from Dr. LaTrenta, and this is really common in younger children with CP. This tends to resolve, especially in diplegics, and they can drift into valgus by age 7 to 8. And this is why I always caution not to operate too early. They also tend to have an equinus, and so in the young patients, you really want to treat based on the equinus algorithm that we discussed. But in hemiplegics, it does tend to persist. You want to always maximize your non-operative intervention first, orthotics, PT plus or minus Botox, and consider surgical treatment for increased callosities, painful orthotic wear, really rigid deformity. And so this is a great paper looking at another Delphi technique. As you can see, the literature in CP is a little bit more challenging than it is in other neurotypical pathologies, looking at assessment of foot alignment and function. And preoperative planning is really paramount. You want to make sure you conduct a thorough physical exam, considering all parts of the foot. You will do an observational gait analysis, which sounds fancy, but it really just means that you are watching that kid walk both in the frontal and sagittal plane in your clinic. If you want to take a video of this, you certainly can to save it in the chart. For those who are lucky enough to have instrumented gait analysis with EMG, this is actually where it can be really helpful to instrument the tibialis anterior and tibialis posterior, because they can both be involved with the child's spasticity and tone. It can give you some sense as to what you really would consider transferring. Another good hack, if you do not have instrumented gait analysis, is to have your spasticity team perform Botox preoperatively into the tendon you are considering transferring, i.e., if a child has varus and you believe based on your exam and observational gait analysis that tibialis posterior is the one that is the most affected, you can have your spasticity team, or if you do it yourself, you can do it, inject into the tibialis posterior muscle and see if this gives you the desired effect. And this is a very good algorithm from that same paper about classification of the foot deformity that can lead to the soft tissue imbalance. So if they do not have a rigid deformity, you really want to focus on tendon transfers. And the workhorse procedure, but there are many techniques, if tib post is involved, is something called the split posterior tibialis transfer. Many people will move half of tib post laterally onto peroneus brevis. There are a ton of different ways to do this. Some people bury it in bone. Some people put it in the cuboid. It's a lot of different ways, but really the key to this procedure is that you have balance and equal tension on both the medial and lateral limbs. Whatever works best in your hands is completely fine. The key is you must balance it, and the foot should remain balanced and neutral. So split posterior tibial transfer is the best option in the right patient. Kids over 8 who have a diagnosis of CP, who have flexible varus. Flexible is really key for tendon transfers. No other fixed deformity. And if you have it, EMG analysis showing posterior tibialis is working out of phase. So does a specific tendon transfer even matter for these? And the answer is no. So when I talked about that you can do, I put it into peroneus brevis, but you can do whatever you like. And that's because there is a study looking at long-term follow-up of equinovarus foot in kids with CP, showing that the determinants of good outcome, like we talked about, the foot has to be balanced. They have to be older. They have to be hemiplegic. The diplegics do not as well. And kids who ambulated beforehand. So no matter what you do, you must get it balanced. That is the key. The right procedure in the right patient. So take home points for varus. More common in hemiplegics, up to 31% will develop varus. Can also be seen in non-ambulatory diplegics. Thorough physical exam is key. You must take into account every deformity and treat it. And there are many procedures that are described for this. All have kind of variable results. And it's probably because we haven't totally figured out the exact procedure that is right for the exact patient. So we're going to talk about plano valgus. We had an excellent talk about this. In CP, it's mostly due to muscle imbalances of the gastroc and the peroneus brevis, causing that hindfoot valgus. They can also have a tibial torsion or femoral anteversion that can also contribute. And they tend to also have weakness and poor motor control, right? All of this takes an effect. And so what you begin to see is that weight bearing on the medial column and a midfoot break. And with puberty and with weight gain, they can get further collapse that's quite profound. So the natural history is, as was talked about even in neurotypical kids, in kids under age 5, it's very unpredictable. You are not intervening. If it's unilateral, it may resolve. It may go into equinovarus as they get older. Bilateral can remain stable and flexible, but it can also stiffen significantly in adolescence. So the evaluation is really important here because your treatment is going to depend on the age, the flexibility, and the tone pattern. Is it flexible? Are they strong? Are they spastic? And do they have good motor control? So there's a lot of factors here. And this is when you really need to be multidisciplinary. If you're lucky enough to have a spasticity team, a good neurologist or physiatrist with whom you work, that is critical to appropriately evaluating these kids. And radiographs, if you say, this looks like a lot of valgus, those are kids that should get x-rays. Dr. Brandt talked about this expertly earlier, but you want to take a look at the talocalcaneal angle, what kind of talonavicular coverage they have, and also looking at the talofirst metatarsal angle. So in terms of treatment, if it's flexible, if it's mild, You can brace them, you can do shoe modifications. Some of these children, as they get older, don't really want to wear braces, and some of them don't have to. So that's okay. You have to work with the patient. But certainly if there's skin breakdown, if there's any pain, you do want to consider a surgical procedure. As you can see by the number of procedures listed, there's really no consensus in CP about what to do. It seems like the children who do the best are when you have considered every single deformity that they have. So you have to treat the hindfoot valgus, the midfoot break, as well as the supination deformity in concert all together. And there are various ways to do that. So another question we get into often is, do you do an osteotomy or do you do a fusion? Fusion is a very scary word, right? Parents hear that and they say, oh, we're going to put your two bones together. It can sound very scary. So there's an excellent paper, which I would encourage you all to download, looking at long-term outcomes of planovalgus foot correction in children with CP. And they looked at, an age-matched control of the osteotomy and the fusion patients. There's a big variety in CP, but they tried to get to the bottom of it and match it as well as they could. And they found clinically acceptable outcomes in both groups. There were improved petabarographs in both groups, but 21% required revision surgery for midfoot collapse, regardless of whether they had an osteotomy or a fusion. So that's something to tell parents. The overall disease does not change just because you are making their foot look good. So if their spasticity is not treated, or if there are other untreated underlying issues, those will continue to persist despite the fact that the foot looks amazing during surgery. And again, this is going to sound familiar, balancing the foot decreases recurrence. So having that overall balance, however you choose to do that, is really paramount. So take-home points for planovalgus: no treatment in kids under 5. Many will remain flexible. Orthotics can be helpful if the deformity is flexible. Thorough physical exam is paramount. Consider all the deformities, what's fixed, what is not, and the contribution of the tibialis anterior versus posterior. There are many prescribed procedures that are described in the literature. All have shown fairly high revision rates. So the most important thing is balance. Here are my references. Thanks very much.
Oh, I'm so sorry, I was muted. So thank you for that. Moving forward on to our next talk, we have Dr. Jessica Hubert, Doctor of Physical Therapy, who will be talking to us about the role of physical therapy in pediatric foot deformities.
Hi, I'm going to talk a little bit about the role of physical therapy in pediatric deformities. I'm a clinical specialist down at LOH in the outpatient pediatric department. Okay, so here are some objectives. We're going to look at some pediatric considerations, recognizing that this is a developing system, it's a growing skeleton, recognizing the importance of early interventions and the role of PT in managing these foot deformities, and some interventions that we can help do that. So the APTA has defined the movement system as the integration of body systems that generate and maintain movement at all levels of function. Cause of movement dysfunction is found throughout the identification of single or multiple system impairments, as well as compensatory strategies that may interfere with optimal movement. As physical therapists, we evaluate movement behavior and underlying impairments in the context of an individual's function and performance. Alignment is everything. Shirley Sarman developed a kinesiopathological model of movement systems. Muscles operate at optimum lengths with appropriate forces when with appropriate force vectors when the joints of the torso and the limbs are ideally aligned. The body follows the path of least resistance for movement. Repetitive movement and sustained misalignments can induce changes in tissues and joint structures. PT treatment is based on correcting the impaired alignments and movements contributing to tissue irritation, as well as the tissue adaptations, including relative stiffness, muscle weakness, and neuromuscular activation patterns. Training to correct impaired alignments and movements instead of training isolated muscles will induce appropriate neural and musculoskeletal adaptations. Right, some pediatric considerations are listed here, and the most important, I think, are recognizing that this is a developing system, knowing norms for development, and recognizing that there are variations within these norms. So the importance of early intervention. The structure and the function of the mature movement system will be impacted by movement experiences during development. So you're still having bones that are not ossified yet. They don't have arches until about fully 5 to 6 years old. And the skeletal modeling occurs through Wolff's law, which is stating that the bones adapt to the stresses that they were put under. So we can see a lot of changes if they have a misaligned foot position that are going to travel all the way up the skeleton. And we know that most kids have flat feet as their arches aren't developing, and that is normal to a point, but because they have intrinsic laxity and a lack of neuromuscular control, and this plasticity in their growth and development of children is to our advantage when we're just watching and waiting with flat feet or maybe toe walking, but it requires more frequent interval assessment in children as compared to adults. So a typical gait pattern, new walkers have an immature gait. It has a wide base of support, decreased stride length, increased cadence, flat foot initial contact, and a high center of gravity. Kids always have their arms up in that high guard. Within 5 months of walking practice, they increase heel initial contact with the gait pattern becoming more adult-like by 3 years old. Our goals in therapy are to improve functional range of motion and proprioception, provide optimal variability of movement, a stable base of support, and the opportunity for good practice. So here you can see how foot position affects the skeletal alignment. Here with the pes planus, the overpronated foot, you're going to get the lower extremities internally rotating. If it's unilateral, you might see hip drop, which can lead to shoulder drop and perhaps even head position. With an equinus foot, and this is just kind of a typical equinus foot, not necessarily a neuromuscular equinus foot, you're going to see some compensations if you ask that child to put their feet flat on the ground. So as you can see in this little guy here, that was him standing on his tiptoes. And when I asked him to just put his heels down, he couldn't do it while maintaining his upright posture. He had increased hip flexion and his trunk just went all the way over. In the image on the left, you can see sometimes if they try to get their feet down, they'll have increased lumbar lordosis, perhaps hyperextended knees. So it's going to go all the way up and down the chain. Here you can see an example of a cavus foot that he's got some increased external rotation to his lower extremity. And with it unilateral, you're going to see some pelvis discrepancy, and he's going to have shifted a weight shift to one side, which is going to affect gait in the long run. So goals of therapy, we're trying to improve the flexibility, strengthen weak muscles, train the proprioception. If their foot is being held in bad alignment and then say it's surgically corrected, their proprioception is going to be altered. So we need to retrain how they can move with correct posture and alignment. We want to promote stable base of support, optimizing function during gait. And we, most importantly, I think, preventing secondary complications from poor alignment. So when we do our PT evaluation with history, you're going to rule out any differentials. Some of the other talks kind of touched on these. Chocard-Marie, a vertical talus, tarsal coalition. Could it be something neurological? Even a tethered cord. You want to find out about their birth history. Was there a NICU stay? Could something else be going on? Family history. Sometimes these things do run in families. If you had a dad who toe walked, you might have a kid who's also going to toe walk. Their age for developmental milestones. When were they able to do all these things listed here? That's going to give you a sense of their overall body function and strength, because maybe if they were very delayed, that they just don't have the proximal strength that they need to perform movement in a good alignment. When this issue began, if it's chronic versus acute, and of course, if they've had any other kind of surgical intervention. So the musculoskeletal exam, it's important to look at the foot and overall alignment in weight-bearing and a non-weight-bearing position. You don't want to just look at the range of motion of only the foot and ankle. You want to look at the whole lower extremity, the hips, the knees. You want to look at the spine. Are they hyperlordotic? Are there any torsional components? Are their hips internally rotated at baseline? Do they have any genu varum valgum? Are they overall a lax kid? Any areas of pain or tenderness? Also look at the shape of their foot. That can give you some information. If they have a really broad forefoot and a little tiny round calcaneus, you know that they're just a chronic toe walker, that their heel has never really met the ground the way it should be. You can also look at the callus pattern and their shoe wear. That can also give you some insight of how they're walking, how their foot is hitting the ground, where they're getting their push off. So looking at strength, again, you're not looking at just the foot and ankle. You're going to look at the whole body. You're going to see, most importantly, their proximal strength. With kids, we often can't just do muscle testing, so we have to examine through functional activities. And I just listed some common things we'll look at just to see how their movement and grade the quality of the movement. So if they're doing a squat, can they control the descent of the squat? Can they get their heel contact? Little toddlers, they're able to be like this guy in the picture where they can just perform that deep squat with heel contact, no problem. Are they able to stabilize? Are they hanging on their ligaments? So those will all give you clues to how their strength is overall. And with the foot, you also want to check foot intrinsics. Can they activate them at all? Can they do a scrunch? If they come in with a flat foot, can they activate the arch with cueing? You see one if they do a heel raise? They're all going to give you clues onto how to base your treatment. So when you're looking at posture, again, you're looking at the whole body. You're looking at the alignment in all planes. You want to look for their common postural compensations. Can they get their foot down? What does it look like? If you have them do a heel raise and come up and down, what does that look like? You also want to make sure you assess their leg length. If there's asymmetrical toe walking, is it just an issue that they have a leg length discrepancy and we need to just give them a lift in their shoe? And also the presence of excessive lordosis. Are they able to access their core strength and activate it for stability? When you're looking at their balance and motor control, here's some things you want to look at. Can they just do a single leg stance? If it's on a unilateral issue, you see big differences in balance side to side. Can they just stay still? Because you might not even be able to, if they have really terrible balance, they might not even be able to stay still. They have to constantly be in motion. You want to look at any strategies they have for managing their balance, and then looking at their motor control. If their foot has been in a bad position during their development, they've gotten impaired sensory feedback up into their foot, and that's our contact with the ground. So that's going to really help us know where we are in space and help with our motor control. Okay, you're going to look at their gait, just checking where their initial contact is. Can they get their heel down? Is it forefoot? Is it, flat foot but with an early heel rise? Are they just totally on their toes? You're going to look at for any compensation, such as hyperlordosis, what's happening at their knees, what's happening at their hips. We often will do an observational gait analysis that we'll score. We'll take a video. If they're a toe walker, you can do the 50-foot walk test, and you want to make sure you observe them with their shoes on and in barefoot, so you can kind of see what's going on when they have the supportive shoes, and try to observe their ambulation when they don't know that you're doing it, because most kids will put on their doctor walk when you ask them to walk, and then you have to ask the parent, is this what it normally looks like? And they'll be able to tell you what's going on. So here are a couple of videos. So here's a cavus foot. You can see what that looks like. See wide base of support, decreased cadence, a lot of lurching side to side when he's moving. Here is a unilateral equinovarus foot. Just see. That's kind of a wild gait pattern. And when you look at this, you can see, I think she was about 5 years old. If she continues walking like this, what kind of pain and other compensations is she going to develop as her skeleton continues to grow? Some toe walking. You can see he kind of bounces along here. No heel contact is really happening. This guy is a little bit hyperlordotic, but not really the worst I've ever seen. Okay, so manual therapy, that's going to be your stretching, your working out your soft tissue manipulation and your joint mobility. This study was interesting because it found that abnormal passive muscle properties are present in young children with CP from even 3 years old, and it was difficult to distinguish between passive muscle stiffness and spasticity during clinical assessments. So it emphasizes the importance of accurately distinguishing these two things so you can avoid unnecessary antispasticity treatment. If you treat with manual therapy and try to break up the relative stiffness of the contractile and non-contractile components of muscle, can you make a difference? And maybe it's not really spasticity. I find this a lot in our older kids who have just been living in a limited range of motion for so long that it's not just their tone, it's really the stiffness in their muscles themselves. Some joint mobilizations. Here are just some common ones to kind of work on increasing dorsiflexion. And limited ankle range of motion in children with CP is associated with higher tissue stiffness, increased relative reflexive torque of the gastrocsoleus, and spasticity and weakness of the ankle joint. The limited range of motion causes changes in the contractile tissue, as I said, and non-contractile. And if you do some soft tissue and some ankle joint mobs, it can improve the range of motion and the gait in these children. Here are some common ways that you can work on soft tissue manipulation. You can use your hands, you can use these tools to kind of help break up that tissue and make your stretching a little bit more effective. Serial casting, it provides a low load progressive stretch over time. It's non-invasive, it's a conservative treatment to try to improve the ankle range of motion. And our goals are to improve the alignment to fit in orthotics, improve gait mechanics, and prevent deformities. It works best when coordinated with PT to work on neuromuscular re-education, posterior weight line training, strengthening, motor control, and gait training. It can be done with or without Botox. I usually, when I do my evaluation, can kind of gauge whether Botox is needed, if it's really super stiff and just not going anywhere, or if we can trial it without Botox to see what kind of progress we can make. And this also works for non-ambulatory children. You don't have to post them for ambulation. You can just use wedging in a boot for when they're in their stander. It's important with non-ambulatory children to also maintain a plantar grade foot because you want them to fit into their orthotics so they have optimal positioning when in the wheelchair, when using their stander, and they're able to get proper weight bearing to assist with transfers. And as Mara said, it's really important to use knee immobilizers and to stress standing and walking if they are ambulatory, because this is a 2-joint muscle and we want to make sure that we're getting that knee extension to really get the stretch on the gastroc and not just the soleus. So here are some common areas that we're going to strengthen and just some examples of exercises that you're going to do, because if you have a teenager you're trying to exercise with, they can just, do their reps of whatever. But if with younger kids, you need to be a little bit more creative and sneak in those functional activities to accomplish what you actually want to strengthen. And you want to consider the use of external supports when you're in a weight-bearing activity. So you can optimize their alignment to work on strengthening the muscles that you actually want activating. So you can use just wedging in their shoes to bring the floor up to the heel. Kinesio tape, simple shoe inserts, or orthotics are all good things to help keep them in better alignment. Here are some strengthening exercises, your 4-way bands, using a weighted ball, heel raises. Little kids, we use these bean bags to try to get them to dorsiflex and put them in a cup or something like that. This is some closed chain ankle inverter, everter strengthening. And the first one is just your intrinsic strengthening, your towel scrunches. You also want to work on their motor control, proprioception, and balance. With our toe walkers, we do a lot of posterior weight line trainings because we need to shift that center of mass posterior to activate those gluteal muscles and their cores, because they usually are relying so heavily on their gastrocs and their hamstrings for balance. We want to try to isolate movements. If we're working toe intrinsics, you can do pickups with marbles or little other kind of toys. You want to make sure you're giving them feedback and sensory information. So you can use texture tiles or shaving cream or even e-stim onto the arch can help wake up that area and get them to use it a little bit more. Here are some activities. Gait training. Again, you want to use your external support, so you decrease your compensations and you get proper loading and gait mechanics. You want to train the way you want them to move. There's no point in training them in an improper gait pattern. You can use auditory or visual feedback. We do a lot of treadmill, incline, decline, partial weight bearing, backwards. Here's some examples of your external supports of just your kinesio taping. And this guy here, you can see how he's so pronated, but just with simple shoe inserts, his alignment looks so much better. And this is the proper alignment. This is where we want to work on our strengthening and our gait training. So orthotics, we want to use them to guide the forces during repetitive movement with sustained proper alignment, so we can encourage the tissues to form in a manner that's compatible with healthy movement patterns. It's not going to limit their movements. They are still going to be activating their gastrocs within bracing, and there's all sorts of different bracing options to really optimize what you want to look at. And you need to pick the appropriate brace prescription because you want to capture the characteristics of that individual's movement system and support anything that's compromised or at risk. So up top, we have just a COFO, some SMOs that allow, if you have a really overpronated foot, this is going to help provide that ankle stability, but the toes are free, so they can still get push off with gait. They can do all sorts of squats. If you have a hinged AFO, it allows a younger child to participate in these squat play. Stairs are all easier. And this is an example of an AFO where it's got some posting to try to bring the heel up to the foot. So you can use orthotics even if you don't have a fully plantigrade foot. And with training, hopefully you can get better alignment. A multidisciplinary approach to treatment will work best. There's challenges to physical therapy with compliance and motivation, parent buy-in to PT, there are limitations to severe deformities. Sometimes we do just surgery is the option that they need at that time. A team approach is the most beneficial because it will provide consistent communication between all parties, cooperation with the other disciplines, including the OTs, orthotists, if they're on board, and important for family education and involvement. It holds the parents and the families accountable, and we want to make sure we're giving the same message to the patients and the families so everyone's on the same page. So in conclusion, we looked at the developing skeleton. We're trying to prevent compensations and future deformities. We want to improve the alignment, normalize their input, improve biomechanics of standing and gait, and that we want to work together as a team. Thank you.
Thank you very much for that. So that brings us to the conclusion of the talks. We have a few questions from the audience that I'd like to spend the last couple of minutes, if we can, discussing. First question is regarding patients with pes planus, and if there's what's our opinion on the use of, I guess, an arthroresis screw, and what age might you perform that procedure? So I'll give it to Dr. Brandt to go over his thoughts on that.
Oh, great. We actually discussed this a little bit before we started the conference. It's something that we have not really adopted here, and I know that it's starting to come. Some of the children's hospitals are starting to integrate that into their algorithm. I'm not a fan. I think that it's a single tool that misses 4 or 5 of the key features of flat foot and the deformity. Even just opening up that joint, there's a 3-dimensional rotational component to that talus that we're not addressing. So I've cared for 2 that have had the procedure done. I took care of a young woman in her 20s who had pretty severe subtalar arthritis following it. I don't know if that was a secondary problem or a missed coalition, but that was not an enjoyable procedure. Did well afterwards, but and then another one that also failed. I think our literature does not support it. The natural history for us is not orthotics and things like that. Those different interventions are not proven to kind of change in the natural history of flat foot or idiopathic or that hyperflexible flat foot as far as the orthopedic surgery side. So that's something that would be awesome if it did work. I just haven't seen enough to believe that it can, honestly. I think it just misses multiple areas.
Absolutely. No, I agree. And what's the famous quote, Dr. Karamatopoulos? I've taken more of those out than I've put in.
Taken comes out. I will say as a caveat to that, I've taken a ton of them out, so I would not recommend it. But we did have a partner who used to do this, who used to put in the arthroresis screws for children with osteogenesis imperfecta who had multiple foot fractures. And there's no evidence on this, but there may actually be a role for it because I've followed up with those kids and their children who had multiple, like 10, 12 fractures prior to the arthroresis screws going in and have had 0 afterwards. So there may be a very limited role for this technology in children with very specific conditions. But I agree. I don't think at this point we could recommend it generally.
Thanks. That's a very good point. Another question was whether we've had any success with casting for patients with CMT. I wonder if Dr. Latrenta wants to comment on that.
I haven't had a patient that I've tried it in, but I do think that it's pretty reasonable. So, you want to get the foot into a braceable position. If it's sort of close, yeah, sure. Try some serial casts and then see if you can get it into a brace. I just think that, obviously we have a low threshold to, move on to some of the other things, the soft tissue releases or adding that tendon transfer in the longest to the brevis to try to get a little more durability in the long run. But absolutely serial casting could be incorporated somewhere along the way.
Great. Yeah, no, I agree.
If I can interrupt for a second, I have actually had some success with casting a cavus foot. I don't get it so often, but the little girl in the video, she actually did amazing with casting. I didn't think it would work at all, but she actually ended up with a plantar grade foot.
Yeah, I think casting is one of those things where it's I don't think it's ever really the wrong thing to start with, at least to see where the foot can go, and in order to address some of the deformities, especially in the younger patients. The last question I have is, which is your favorite procedure for patients with tarsal coalitions? I guess I'll leave this to everyone. I guess maybe you'll start with Dr. Brandt since he showed some of his cases.
Yeah, I mean, I didn't really get into the procedures, and I think the spectrum of what you have to do for tarsal coalition is pretty broad. So I love I don't do it very much because I don't think it's necessary, but the all around the world flat foot correction to me is one of the coolest procedures that we do, just the process of it. It's very
Mhm.
stepwise and systematic. And so anytime we do a coalition and we have to address the other issues, to me is a good one. But the coalition, that simple CN it's always nice to see the window.
Absolutely, yeah, and I think that that oblique view that you showed fluoroscopically, where there's this like almost like a bright white light right in the middle of where you resected it, I think is beautiful. Yeah, for with regards to correcting, the whole foot as well, I think I initially in early on in my practice I shied away from that, but now I realize those are some of the most appreciative patients, and they're very satisfied with that correction when you get it done. All right. So I want to thank everyone. This has been a lot of fun and hopefully educational for everyone. I know I definitely learned a few things, and don't want to keep everyone too late. So thank you for your talks, your informative talks, and your engagement. And I want to thank everyone for attending.